Hello, and welcome to the Early Childhood Health Consultation April webinar titled Catching Up on Checkups. My name is Maria Morgan, and I'm the project manager with Early Childhood Health Consultation. Our team is so excited for you to be joining the webinar today. Our program is in partnership with the Wisconsin Department of Children and Families, housed at University of Wisconsin-Madison School of Human Ecology, and funded by the Preschool Development Grant. Our program's mission is centrally focused on supporting Wisconsin ECE providers in offering guidance on best health and safety practices. Our program envisions a sustainable and statewide model working through health consultation and centrally focused on promoting the health and well-being of children across Wisconsin. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to a partnership to improve tailored support to best meet the needs of each tribal community. Our program offers general guidance on best practices for health and well-being in early childhood settings. Any questions about a specific child should be directed to that child's primary care medical home. For today's webinar, we will begin with introductions, have central content, time for question and answer, and a few closing remarks. If you're interested in receiving Registry Continuing Education credit, please stay tuned to the end of today's live webinar event, where we will include a survey link in the live webinar chat. If you're interested in exploring the resources and recordings of today's webinar, please check your email for about a week after the session, where you can expect the webinar recording and the slides. There are a few Zoom webinar features enabled today during our live session. The first is the chat. Feel free to enter questions throughout our presentation. You can use the drop-down selection to send your message to the host and panelists or to everyone. We also have the Q&A feature. You are welcome to enter your question and check the box if you'd like to send it anonymously. And with that, I'd like to turn it over to Early Childhood Health Consultation Program Director and Pediatrician, Dr. Dipesh Navsaria.
Hello, good afternoon, everyone. It's a pleasure to spend some time with you this afternoon talking about well child visits. We're going to talk a bit about the components of well child visits, talk through a few resources that lay out what these are and how to support parents in learning about them, and then, of course, how ECHC can be helpful to you in all the ways that you might have questions about health and safety, but also this one. So some of the slides that I show you today are actually literally the slides that I use to teach some clinicians. I routinely do a talk on well child care to our physician assistant students, who of course are some of the folks that are out there in eventually in Wisconsin who will be doing well child care. I promise I will not give you a talk to the same technical level that I would to them, because there's a lot of things that you do not need to know about. But I just wanted you to know that some of these are actually the same elements that I share with them and show them. I also hope to give you some guidance that you can use with supporting families in thinking about what they should expect from well visits and what kinds of things they can ask about, or should feel comfortable bringing up in different ways. So one thing that I always point out, because people get worried about this especially in healthcare, they're often convinced that, well, children are so different. There's no way that anything that we do in kind of adult medicine could apply to them. And I always start off by pointing this out. Yes, children are different. They're different sized. They have different developmental needs, as different things that come up in terms of their health. And it's important to recognize that. You all know that. I don't need to sell you on that, but other folks sometimes need some reminders on that as well. But at the same time, children are still, last I checked, still human beings. And many of the things that we think about in terms of health and safety are not necessarily all that different from how we might approach them in different ways. Now, you may hear a wide variety of things when it comes to people talking about their child's checkup. And you might wonder, well, is is their regular doctor not doing it right, or skipping steps, or not addressing everything that should be addressed? Well, the secret is that there's no such thing as a single right way to do a well child visit. And this may come as a surprise to you. There are certainly templates and checklists and guides and all that, and we'll talk about a few of them, right? But the reality is that there's no rule out there that says you must do it this way. And I'm going to tell you that's a good thing. It's a very good thing because it lets us center the time we're spending with families on what their needs are and their child's needs are, and not going down a template. And I'm also going to say, unfortunately, there may be places that do go down a list or a template, and it's about the template and not about the child and family. And I hope those folks realize that it's not a particularly satisfying visit. I don't think it's satisfying for the family if they feel like they're simply being asked yes, no questions, and you know that's the whole of it. It's not good for the child's care because if something didn't get asked or brought up, then okay, maybe the family doesn't feel comfortable now. And then, of course, I don't think it's actually all that satisfying for the healthcare provider. Asking simple yes, no questions over and over again doesn't seem like a particularly engaging way to have human interactions. So I always want to highlight you may hear variety even in your own center between how different places do things, and that may actually be absolutely okay. There's some things we ought to be doing, and we'll come to that in a moment. So, having said that, and having laid out this idea that the well child visit really should be centered on the child and family. And oh, let me say one other thing. The words we use sometimes get confusing. Let me throw a few phrases at you. Well child visit, checkup, physical, health supervision visit. All of those are the exact same thing. They're just different words we're using for this thing that we're talking about. I personally prefer well child visit because it reflects that the child is well, but there's a visit that should be happening and it's not about an illness or a chronic condition or an injury or anything like that. Um, Health supervision is probably the more accurate term, but sort of technical, right? So I don't use that outside of you know, medical, meetings and things like that. Checkups are fine. People understand what that means. I don't actually like the term physical because it implies that the only thing that matters is the physical exam. And I'm going to tell you, the most important thing is actually the history. It's the questions we ask. We learn way more about how to properly address that child's health from the questions that we're asking in a careful manner, and the conversation we're having than actually from the checkup, from the physical exam. The physical exam adds very little to the visit. I'm not arguing that we shouldn't do it, simply that that shouldn't be the emphasis. So this is what I tell people to start with when I'm doing clinical training. Say your hellos, all that business, and then say, before I go down my list of things, what would you like to discuss today? And again, that centers things on what the family's needs are. And I tell our trainees, if you discover that this family is about to lose their home, had a major significant death in the family, and they're reeling from that, whatever the case may be, please put down your lists and your templates and your guides and focus on what their needs are. There's no rule saying that you need to go down those other things. In fact, I would argue scrap the well visit, turn it into a visit focused on what the concern is, and then catch up on the well visit as soon as you can. And that also gives you another opportunity to check in. Again, nothing wrong with that. No system should be preventing clinicians from responding to the immediate needs that are there. So, what's the schedule? Many of you are probably familiar with what the schedule is, and I've gone well beyond early childhood in this list here. Um, of course, there's an exam generally in the hospital if the baby was born in a hospital in the first few days of life. There's a visit right after they're discharged from the hospital, and that can vary by a few days based on what the needs are. Is this child losing weight? Are they jaundiced, etc.? Sometimes we might say you need to follow up like tomorrow, and other times we might say, you're fine for 2 or 3 days, and so on. So that will vary. There's another visit at about 2 weeks. Again, check up on weight and those sorts of things. Again, this assumes there's nothing else of concern. There's usually not a 1 month visit anymore. This is kind of faded away over time. And then we see visits at 2, 4, and 6 months. And then we go to an every 3 month cadence from 6 months up to 18 months. And then we go to every 6 months through about age 3. You notice I have 30 months there in parentheses. It's been quite a few years, but that was the most recent addition to the well child schedule. And you'll still find clinics that don't do it. It's not the end of the world, I suppose, but it is something that should be happening. And then it's once a year. It's a more acceptable to do it every other year when you get up to age 7 or so. And then with adolescents, we go back to every year in theory. That doesn't mean that it necessarily happens. It's just that's what we would like. Now, I want to highlight the last line there, school, sports, etc. There's sometimes this idea that, oh, you need to come in for a school physical. That might be for high school entry. It might be for Head Start, or for another type of early childhood education, or so on. Or, oh, you need to come in for their sports physical. And sometimes people talk about this as if these are completely different types of visits. I want to say very clearly to you that any of those should be the regular standard well visit, maybe with something added. Uh, Paperwork, maybe, or addressing certain needs. So, and this is part of why I don't encourage people to go to, sometimes there's places, urgent cares and others that say, oh, get your sports physical here, $25, right? You're going to a place that doesn't have your record often, does not have any prior connection or relationship with you, and they will do the minimum needed to clear them for sports and sign the papers and get you out the door. Well, just because you're in for a quote unquote sports physical doesn't mean we shouldn't be asking about school performance. Just because you're here for a Head Start physical doesn't mean we shouldn't be asking about family life and about nutrition and other things that if they're not asked about on the form, oh, we shouldn't do them. What I'm trying to say here is that well visits should be there for the reason for which they're intended. And if we're adding on some paperwork or another need, like some small extra screenings for sports, that's fine. But they shouldn't be this completely different thing. Okay, so when in the room, how do we structure the conversation? And this graphic that I'm showing you here actually comes from a paper of how we teach medical students to think about like the questions that they're asking. And you'll notice that there's not a lot of specificity in this mnemonic, which conveniently spells out the word checkup. Um, but it kind of just gives you a frame so that it doesn't force you into kind of saying, oh my goodness, I need to ask these 40 questions that are on this list in front of me. Um, so start off again, the concerns, like I already showed you. History, what's changed since the last time you were in, or if this is your first time? Tell us about past medical history, how birth went, family history, social history, etc. What's the child's environment like? You know, what's the home like? Who's at home? Where do you live? Those sorts of things. What's a typical day like? Tell us about how feeding goes, feeding and drinking and all that. And sleep, how does that go? Some other things on development, which also are, of course, the usual developmental questions, fine motor speech, all that, but also growth and also voiding, peeing and pooping and all that sort of stuff. Ask about concerns again, maybe some things that come up in the process of people talking, of you asking questions and the family thinking about it. And then offer what we call prioritized anticipatory guidance. You may or may not have heard this phrase, anticipatory guidance. It's one we throw around a lot in the world of pediatric healthcare. This means you're giving guidance, but you're anticipating its need before it's necessary. So I'll give you an example. Um, Children are often walking around 12 months of age, give or take. And families may not have thought about, childproofing for, a walking toddler. They may only be thinking about a child who's crawling and maybe not able to even stand yet, and so on. Well, if you wait till 12 months, well, that child might already be walking and they might already be smacking into things and getting hurt and things like that. But if you bring it up at, say, 6 months, right, anticipating crawling will happen and then walking, in the following months, you're anticipating their need for the guidance before it gets there. Not only is that more helpful to the family, frankly, they'll listen, they'll hear it, hopefully they'll follow through with it. And when they do it and say, oh, look, he's walking, he's getting into all these things. Remember they told us to do this? You look like a genius. I would argue that probably many of you do this already, right? In term when you're talking with parents about things they can think about that are good for their child's health and well-being and development in all sorts of different ways, because you know what's coming, and if they don't know or they're not sure, you can help offer that guidance to them in different ways. So again, this is just another way of how I share these things. I particularly like digestion because it's basically the basics of what goes into the child and what comes out, no matter where. Just let's find out about all those sorts of things in different ways. Now, you may be wondering, right? Gosh, there's got to be a lot of details out there and on how to do this. And yes, there are. There is a program called Bright Futures. This is funded by the Federal Maternal Child Health Bureau, and it's done together. They contract with the American Academy of Pediatrics to do this. We are in the fourth edition of this work. We're just starting to gear up on the fifth edition. I was on the infant expert panel for the third edition, so got to help write it along with many, many, many other people. It is a rather thick book, something on the order of 650 pages. If you're looking at me on the video here, it is somewhere right about where my finger is. Those really big white blobs are Bright Futures, the printed manuals. These are available online free because this is your federal tax dollars at work. So you don't need to buy this if you're curious about it. You can go and look through it as yourself all you want. And it's in two parts. The first part talks about themes that cut across ages, like healthy eating. Um, you can talk about healthy eating in an infant. You can talk about healthy eating in an adolescent, and you can talk about that in all the ages in between. So it's nice to have those themes to kind of see how things evolve over the years. And then the second half of the book is by age range and offers things that should be happening at each of those visits that I mentioned. And we'll look at a little snippet of that in a moment. I want to show you one other document which is associated with this, which is also a free download. This is something we call the periodicity schedule. And this is a one-page chart, and I'm only showing you a snippet of it here, that says what's the stuff that should be happening at each visit. And this is handy to download if you are wanting to kind of have a sense of what should be happening at the different age visits that young children go through. If there's a round dot, and you can see there's a fair number up there, that means it ought to happen at that visit. If there's a star, it means you might want to do this. It depends on the circumstances. So, for example, the first line up there, history. Yes, that should happen at every visit. Duh, right? Like, why would you not do that? Weight should be measured at every visit. Blood pressure, on the other hand, is actually not something we routinely measure in early on in life. It gets done, in the hospital after birth. But after that, there's no reason for us to be measuring unless there's a concern or question or prior issue. And that's why there's a star there. Some of these things are a little more general, like things like developmental surveillance or behavioral assessment that can constitute a whole bunch of things. And then some of the lines don't pop up till later, like we are presumably not asking young children about their drinking habits and their use of of illicit substances. That's more for later on. Those categories on the left, I want to show you in a little more detail, just so you can see the fullness there. That's most of what we just saw there, in different ways, including, you notice all the screenings that we recommend. Again, this is going from birth all the way to age 21. So maternal depression screening is not going to be relevant after a later point, as something you should do at every visit. Screening, by the way, is something that we do with everyone, in an organized fashion using a tool that's been validated and normed and evaluated in all the ways that we do. It's not something where you say, well, you look like you need this, therefore. Surveillance, and you notice there's developmental screening and developmental surveillance. Developmental surveillance, that does not mean we hide out, out on the street in front of your house with binoculars like, an FBI stakeout. It simply means that you're looking at interactions, engagement, what's happening in front of you at a visit, what concerns are brought up, and maybe you dig a little deeper. It's not as universal and as strict in the definition as screening is. It's still valuable, and that's why both of those things are up there. Developmental screening, as you may recall, an example of that is the Ages and Stages questionnaire. There's other questionnaires out there too. That is a validated, normed instrument that helps us keep track of child development, and look to see, is there a concern here? It's not a diagnosis. It just helps see, should we be doing more? As we continue down, you can see all the physical exam things as well. Again, some of these are things we're doing with young children, like screening for anemia, lead, doing immunizations, etc. Some of these other things apply to much older children in different ways. Again, I've not given you, if I put the whole periodicity schedule table on this slide, you would not be able to read it because it would be really tiny, but you can download it and look at it if you so desire. And then oral health, and then of course anticipatory guidance at each and every age. What I also want to show you now is that that 650-page manual is pretty heavy. What they did was they created a pocket guide, and this is one page from the pocket guide, and this is from the 15-month visit. It does not offer you the why we're doing certain things like the full manual does. It's just reminding you what to do. So this is handy in terms of like, this is what we're trying to think about at each visit. So a trainee might look at this before walking in the room to remind themselves. And you notice some of this is like, what are we supposed to observe? You notice there's a lot of relational health here. The emotional tone between parent and child, how are they connecting? How does the parent react to praise, etc. There's things we're supposed to look for in developmental surveillance, which we just talked about. Things we should be doing in physical exam. This should be consistent with what I just showed you on that periodicity schedule. There's screening that may be done at that age. And then immunizations. Immunizations change frequently enough, and we'll talk about them in a moment, that they decided not to list them out in here, but just say, go look at the latest chart. And then here's anticipatory guidance. Some is around communication and social development, around sleep, those sorts of things. If you go to the next page, the facing page is also the 15-month visit, temper tantrums and discipline, oral health, and then general safety. And that's it. On 2 pages, they've kind of listed out everything that we should be thinking about. Now, this is a lot of stuff. So if you don't spend your time in a well visit looking at each and every one of these things, that's okay. And maybe some of these things you don't actually verbally address, but you have on a handout or something that you ask the family to review when they get home, because you can't remember everything in a short amount of time. So for example, the stuff about, I'm looking at the right-hand column there towards the bottom, install a home detector on every level, test it, set your hot water to under 120 degrees Fahrenheit. Probably in most instances, we may not have the time to say those things, and hopefully we've said it at earlier visits. So just having it there on a written document for people to review and look at later is also okay. Because if we read through all of these things, we won't have time to dig into what really they need. And number two, man, they're not going to remember anything if we don't focus on the key things. The other thing is, childhood has changed in just the last 100 years. Um, a child that's born, parents generally have every expectation that that child is going to grow up and make it to adulthood easily. We don't live in a time where childhood death is a common thing like it used to be even 100 years ago. So as we've improved in so many ways, thanks to public health measures, yes, sanitation and hygiene, but also immunizations and antibiotics and things of that nature, what we're seeing is that well visits have become less and less and less about look for disease, and instead are about preventing disease, but also about aiming at other things like development. How do we help make sure that that child is going to develop strongly? And I would argue your job has also changed in the last 100 years because now it's not just simply about, well, kid needs to be here, while parents work, but it's also about how do we help this kid flourish and thrive in different ways. We talked a bit about screening. I want to give a few other examples. Some are things like vision and hearing. That's awfully hard to do in a young kid, as you can imagine, but we do have some gadgets that help with that. And of course, if there's any questions or concerns, we'll call our friends or appropriate friends to who do have even more gadgetry and techniques to be able to sort this out in different ways. Of course, we screen for lead and hemoglobin. And as you may recall, lead screening used to be a series of 7 questions. And if answer to any of them was yes, then you did a blood screen, usually through a finger poke. And that was also a way you could check for anemia. As of just a couple of months ago, they are in Wisconsin. We're now recommending blood lead screening for all children, so you no longer have to ask the questions. Because frankly, it's good to check for it because the effects on the long-term effects on a child's IQ are so significant that we should just be checking. And then if it's positive, following up to try to protect them from further lead poisoning. This developmental screening, which I mentioned, with things like the ASQ. And then the screening that we've started to add in some places are psychosocial screeners, which are about the things. SDOH is social determinants of health. This means things like food insecurity or housing, things like that. So screening for those sorts of things. ACEs, which is adverse childhood experiences. I'm not saying we do these with everyone or should do them with everyone. Just that they are things that are out there that we might consider doing depending on our patient population and other things that we are trying to address, over time. And of course, what we do in the actual physical exam changes. I'm so not going to walk through each of these things because we will get off in the technical land. With infants, we're looking for, specific general exam, but also specific things, looking for heart defects, hip dysplasia, things like that. Of course, immunizations, lead screening. When you get up to the toddlers and the preschoolers, you're more able to look for visual and auditory things, immunizations and lead. And then as we get older, past early childhood, we start also asking about school. And with adolescents, in particular, right, all the other things that go on in their lives, around their home life and substance use, sexual behaviors, et cetera, et cetera, et cetera. So let's turn for a moment to immunizations. I don't anticipate that you are able to read everything on here, and that is fine. This is the current 2024 childhood immunization schedule. And everything's right here on one page. There's also a second page that has a lot of footnotes to it. So it's not everything, but close to it. And what I want to point out to you is that there's a fair number of things we immunize against, and we do those things because they're important. One thing that's not on this list, which was on this list when I was a child, is smallpox. because, hey, guess what? We've eradicated smallpox from the globe. There is no smallpox left anywhere on the globe except for two labs, one in the US and one in Russia, I believe. Those are the only places where smallpox still exists. It is not in the wild and has not been for many, many years. So we stopped immunizing because why? It doesn't make any sense if it's not out there anymore. And that is an amazing success story. There are some things which you might think we've eradicated, but we haven't, like polio. We still immunize against that because there are pockets of polio still out there in the globe. And we all live in a world now where you're pretty much one plane flight away from many, many places. And it doesn't take that long for someone who may not be showing symptoms to be back somewhere else and then potentially spreading something without even knowing it, right? Certainly, COVID taught us that in many ways. We're close on polio, but not quite there. It's been really stubborn to get those last few pockets done. Some of these things you will never be able to stop immunizing against because you can't eradicate them. Haemophilus influenzae B, which has nothing to do with influenza despite its name, pneumococcal vaccine. These are things that live in our nose and throat routinely. All of us on this call have probably billions of those living in our nose and throat, and that is normal. It's just when they decide to invade that they cause problems, and like meningitis in young kids. I'm so happy that I have rarely seen a case of Hib meningitis. um, I actually saw a case of not meningitis, sepsis, bloodstream infection, a few months ago. I diagnosed it or came up, I recognized it was sepsis. I did not know what was causing it. That was up to the hospital to figure out a few days later. But I knew that that child needed to be in the hospital. That was an unimmunized child. It was not that the family disagreed with vaccines. They just never came back in for well visits, kind of in the latter half of the pandemic. They thought, well, there's sick people in the clinic. Let's not go there. And things got put off and put off long enough that I looked at this child and said, this child looks way sicker than any child I've seen like that entire year. Something's not right here. And indeed, they had a vaccine preventable disease. They did fine. They went home, hopefully getting caught up on their vaccines now. Yeah, and I'll just highlight a few other things. Measles, mumps, rubella. I just saw the news a couple of days ago. There are more cases of measles in the United States in this calendar year, in 2024, than there have been in prior years, the entire prior years over the last several years. We have a fair number of measles outbreaks going on, which should not be the case. And it is unvaccinated individuals that unfortunately are spreading it. And measles is extremely contagious, makes COVID look like nothing. So, and then some of these are older age groups, as you can see, that don't affect us directly in early childhood. But this is the schedule. Some very, very smart people who have looked at tons of data have come up with this and decided what provides the best and most optimal protection. And they've managed to line up a whole bunch of them. So some of these actually come in a combined form. You sadly can't just take the vials and mix them all into one syringe. It doesn't work that way. But some they've managed to do that and test it to make sure that it works well. So it's not necessarily individual injections for each of these. A few of these are oral. The most are injectable. So anyhow, people often think, oh, shots are the main reason to come in for a well child visit. And I would encourage you to remind families that while they're really important, they're not the only reason to go in for a checkup. And that we do all that other work, the surveillance, the history taking, et cetera. And if their child isn't getting shots that day, it's not a wasted visit. It's actually important because a lot of other things happened as well. I want to point out just a few other things before we move on to some questions. This is actually from the Bright Futures Manual. It's about us taking the opportunity with young children to talk about early literacy and about reading together, about shared reading, and about all the things that benefits that brings to that child and family to their long-term outcomes, their brain development, their school readiness, et cetera, et cetera. Many of you know that I'm the medical director for Reach Out and Read Wisconsin, and I'm on the national board for Reach Out and Read. So it will not surprise you to know that I actually wrote this box that's in the Bright Futures Manual. But again, just want to highlight, right? It's not simply about shots and blood draws and physical exams. A lot of it is about how we can support families as well as we can. And then finally, I want to say just a couple of things about growth curves because there's a lot of interest in this and sometimes some misinterpretation. Now, in this day and age, most of these get plotted out electronically on our screens, which is great because you're not making little dots on a piece of paper anymore. But these are what the growth curves look like. And the bottom kind of set of curves is weight, and then the top set is length in this case, which is the equivalent of height in a young child. And it's important to recognize that the reason there's a whole strand of lines there, right, that are all kind of paralleling each other, is because there's a wide range of normal. The dark, thick line in the middle is the 50th percentile. Okay. What that means is if you are that weight at that age, then 50% of kids in the study group that they did are heavier than you, and 50% are lighter. Okay. If you're in the 90th percentile, then 10% are heavier and 90% are lighter than you. So it just shows you there's a broad range there, and sometimes we have this tendency to be like, oh no, they're not right on the 50th percentile. Well, that's okay. Human beings come in all different shapes and sizes, and as long as it's not too far off or falling off. So sometimes trainees will come out of a room and they'll give me a number, and they might even give me a percentile for their height or weight, and I'll say to them, okay, yes, but show me the graph. That child is 10th percentile? Okay. Have they been 10th percentile for the last year? If so, that's consistent with where they are. Or were they always 80th percentile and now suddenly they're at 10th percentile? And by the way, if they drop that quickly, my first question is, did somebody get this weight correctly? Can we just remeasure and check? Because that's a pretty quick drop. And sometimes you find an error and great, there's no problem here. It's just, bookkeeping or measurement error, and great, we can fix that, and so on. Or is something going on, and we need to dig a little bit more and figure that out. And I want to show you a couple of examples of how this matters. The original set of curves that were used for many years in the United States were a sample done on white suburban children in Ohio, I think was the study group. Which is fine, except it's not very representative of the diversity of the United States as a whole. So in the 1990s, the CDC did a much more representative one and created new curves. The World Health Organization did an even better one, and that also represents a wider array of foods and eating styles and all that are out there to reflect what's normal, right? That's out there. And I want to bring this point home to you for a moment here. I want to walk through two patients with you. These were actually patients of mine. These are their actual growth curves. Okay, this kiddo, you can see from the X there that this is what their 6A. This is just before maybe their this is their 9-month visit. And okay, you notice there's a little set of 3 X's around 6 months that drops off pretty suddenly. What might be going on there? Well, a couple of things. Might have been an illness and they just weren't eating well for a little bit. Might have been that they went to different clinics in our system and the scales weren't necessarily as well calibrated. The scales are checked, but there's actually no rule about how often they should be checked that's universal everywhere. Most health systems will have a regular, recalibration and all, but the scale at the supermarket where you weigh your produce is more regulated and more checked than scales in doctors' offices, believe it or not. So maybe it was, and maybe they left on clothing at one of these visits or not. Hard to know. But then you notice a few months later, right? Like, oh, this kiddo is now at the 25th percentile, and they used to be up at the 75th percentile, right? From um, roughly 4 months of age to about 6 months. Oh no, they're 25th percentile. What's going on? Are they not getting fed? Do they have some sort of disease or illness? What's going on? Well, this is on the CDC curves, the newer, quote unquote, new ones in the 1990s. Let's take the same data and replot it on the World Health Organization curves. Because this is a family that are Latinx immigrants from Mexico, I believe. They still follow their relatively traditional eating patterns that they did in Mexico. So let's use the WHO curves. Exact same data, different curve. Oh, look at that. You know, this kid's writing right about the 50th percentile. Nothing to write home about. They're good. Okay. So this shows you there can be bias sometimes even in the curves that we're using there. Let me show you one other example. Here's a kiddo was up at about the 75th percentile at maybe 4 months of age, and then they start to fade and drop off. And now at 12 months, they're below and they're sinking and going down further and further. And now we're seeing them at about 2 years of age, and they're close to the 10th percentile. My goodness, do they have a malabsorption issue? Do they need to see a gastroenterologist? Do I need to consult a dietitian? Or maybe I replot them on the World Health Organization curve and discover that they are almost smack dab on the 50th percentile. There's nothing wrong with this child, right? So we always need to be thoughtful about biases that might creep in on things. So if you, for some reason, some centers might sometimes plot weights and things like that. Just think about that and approach these things thoughtfully and with curiosity, because sometimes we start finding problems, quote unquote, where there aren't any. So this gives you, I hope, an idea of the wide range of things that we talk about in the world of well child visits. We're looking for a lot of things. We're listening for a lot of things, and trying to do our best to support children and families in their health and well-being as they move forward. So let's move on to your questions. And just as a reminder, you can put your questions in, either the chat or in the Q&A feature. And I do see there's a couple of questions already there. So I'll start addressing that while people might be thinking about other things. One asks, how do I encourage parents to take health checkups seriously and take their children to the doctor? And then how do I get parents to hand in their 6-month reports to my child care center on time? I don't have a great answer on the second part. I think, different types of incentives, if they're just not handing in the reports, I think thinking about ways to incentivize that and make sure they get it in would be something to think about. And you can think about what might be socially acceptable. It's always nice to, dangle carrots in front of instead of waving sticks. So um, maybe there's some small thing you can give them or give their children. Well, let's not get the children in the middle of this. Give them as a thank you for doing that on time. Frankly, much like how young kids love stickers, you can get an awful lot out of people if you simply give them a piece of chocolate or something for for doing something. So maybe we need to use some of those child incentivizing techniques with the grown-ups. But as for the how do I encourage them to take it seriously and take their children in? That's a good question. And I would say this is where I would encourage you to be curious. Um, you know, we know that children, the checkups are there for good reasons, right? And it's something that's really important to kind of make sure that we're not missing problems that might exist down the road, and to catch different things and to make sure they're getting all the stuff they need, like their immunizations and so on. Um, to tell me what's getting in the way. Often you'll find that it's not actually someone saying, I don't want to go in for a checkup or I don't think it's important. But what they're saying is, um, it's hard. Maybe they moved to town or the area and they just never got anything set up and they're just not even sure where to go. Maybe they had a bad experience before. Maybe their child had a bad experience. And they're just like, yeah, it's just easier to not deal. I think being curious about the reasons and then seeing what you can do to help. Um, Sometimes people aren't even sure, like, who do I ask about a good place to take my kid that I can trust? And if you say to them, oh, I've heard really good things about so and so, or I took my own kids to so and so, that goes a long way. So I think finding out the reasons is probably the best thing to think about. Another question asks about how do you talk to parents about not worrying about their child's weight as a teacher? And I think this is an interesting one. I had a lot of families actually who would tell me that they were concerned that their child was underweight. And I had to I would actually pull out the growth curves and plot it and look at the trend and all those sorts of things and show them where their child was in this range of normal and whether they were growing consistently for them over the months and years. Excuse me. And I think that was really helpful for them. And I would also have to point out that unfortunately, with a fair amount of obesity in children, a normal weight child can look, quote unquote, too thin or underweight or scrawny because of a fair number of children who are overweight. So we need to keep that in mind, as well. I think again, the question is one, what's worrying them? And what are they worried it could mean or represent? For many parents, it's I'm worried that they're not getting the proper nutrition, and then that reflects on me as a parent, right? That I'm not feeding them enough, or I'm feeding them the wrong things, or whatever the case may be. And number two, please, 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 please encourage them to talk to their primary care clinician about their concerns. Okay. They really should be raising those concerns. And if they feel their concerns are not being taken seriously, you know, it's perfectly okay to suggest that maybe they should think about switching to someone who will take their concerns seriously, right? Because having concerns taken seriously does not mean we run off and do testing in every single situation. Okay, that's not appropriate either. But someone should be willing to listen carefully, understand what the concerns are, and either follow up if need be, or offer reassurance with an explanation as to why. Okay, and I think that's true of not just nutrition and weight, but of all things. Everyone deserves that, no matter what, frankly, in any healthcare interaction, period. Um, if we're not talking clearly to people and addressing their needs, then we're not doing our job as a profession. So, I see some other questions popping up here. How can I encourage a parent to get their child vaccinated? I, I think the challenge here is that there's a lot of misinformation out there. And you may recall on a previous webinar, we've talked about, and on our podcast about misinformation and disinformation. Disinformation is when someone deliberately spreads poor information, bad information on purpose. They want to create problems and all, and they know they're doing it. That's rarer, and that's often where these things start. Um, the misinformation is you think it's actually true or probably true, and you're trying to share it with others because you think it's important. And it's being usually done with best intentions, but not actually looking into, well, is this really true or not? And I think it's important to let's remember some common values here. And I've said this with families. I have one of the same basic goals that they do, which is to keep their child happy, healthy, and safe to the extent possible. Okay, that's my goal. That's their goal. We can agree on that 100%. So let's just start by acknowledging that this is not about us being against one another or, butting heads or whatever. And I think it's really, really important to think about how we, start with that and then start with, immunization is important. It keeps them safe. It keeps the classroom safe, it keeps families safe, it keeps communities safe. And I always emphasize the most important thing we have to remember, vaccines save lives. Okay, we know this. There's many, many, many people around who are here because of immunization. And we need to keep the focus on those positives and not um, necessarily on the misinformation that's out there, which is largely untrue. But let's not sit there and debate every little last point on those sorts of things and just recognize the big picture here. Um, there's a comment. I'm going to say I think parents do care about healthcare when it comes to their children. I think there's a lot of competing factors. Look, um, if you're being told you need to bring your kid in for their 12-month checkup, okay, but you're also being told you need to show up at this office in order to get your WIC coupons and your SNAP benefits reloaded. And you need to show up here so that way you can get your voucher so that you can pay for your rent because of the housing that you're in. And it's a lot easier to put off the 12-month visit and say, oh, I'll get to it next week, or I'll get to it the week after. And before you know it, 6 months have gone by. I mean, I don't know about you, but I'm occasionally guilty of sometimes saying, my goodness, did I really completely forget to schedule my dental cleaning? And now it's been how many months? Yes, I've done that. Okay, we've all done that. So um, I think it's recognizing the competing priorities that get really loaded on people, particularly people living in poverty. But I think everyone can face those challenges, even people with a lot of education and privilege and so on. So I think let's start with assuming best intentions and trying to help them where we can work through those issues. And sometimes we can get creative. Um, I'll tell you, I've done a lot of work with a tribal health center and tribal Head Start in the state. And we discovered that we were writing all these prescriptions for fluoride supplements because there was no fluoride added to the local water and there was very little naturally occurring fluoride. And we were seeing the effects in children's teeth with decay and so on. And we were writing all these prescriptions. And then someone told me, by the way, most of these prescriptions are not getting filled, or they're getting filled once but never refilled. Okay, great. We're patting ourselves on the back that we're writing all these prescriptions. Yet, if the fluoride's not getting to the kids, we may as well be doing nothing. So we put our heads together, and the solution, again, Tribal Health Center, Tribal Head Start, all working together. So it's a little easier than in other places. They decided they would just have the dental team, they'd get permission in advance. The dental team would just show up periodically at the Head Start and apply fluoride varnish to the kids' teeth. Great, wonderful, done. It was a wonderful solution and didn't and involved us not having to kind of sort out all the other challenges that might exist with getting the fluoride to kids and making parents do it. The parents were actually, I think, relieved. Like, yeah, sure, I'm good with it. You do it. That's one fewer thing I have to do. And it was actually a lot easier than everyone writing prescriptions and wondering and whatnot. So. Following the chart for wellness checks, do you follow this for all ethnic groups? Yes. All kids are kids. There's no difference based on that. Kids might have additional check-ins based on some sort of chronic illness or condition that they have, right? But that's not well care. That's care for their chronic condition. There's no difference between any of those groups in different ways. Yeah, and again, I think there's so many challenges that families are facing sometimes, and trying to be curious about that and see what we can do to lift those burdens is important. I'm also going to say there's some really interesting initiatives being done in a number of places. Flint, the place unfortunately famous for the water, the lead contamination and the water crisis, is doing one of the first universal, everyone gets it, no questions asked, cash transfers to families with young children. And they are just giving cash to families and letting them decide how to use it. And they are seeing great results. And they are trusting that families are going to use this well, and they're largely seeing that. I'm really excited to see how that plays out. It's been done in smaller scales, on a smaller scale in other places, and all. And I'll take one more question here. If my child was immunized as a child, can they still get measles, mumps, or mumps as an adult? They're in their early 20s now. Um, you know, different vaccines are different because the diseases are different. The data shows that measles, mumps, rubella seems to be lifelong immunity, and protects most people their entire life. Yay. Does not need to be reboosted or redone. That's not to say that's a guarantee that everyone's 100% immune, but it's so high that, again, if the population's immunized, we don't have it spreading, which is the whole point. Other things only last a short period of time. COVID's an example of that. Tetanus, right? We had to update that every 10 years, because it doesn't seem to last. I will not bore you with, the details of the immune system, just to know that, man, if we could do all these things just once and leave them alone, we would. And how do we encourage parents to offer more fruits and vegetables? Gosh, I don't think that's introduce new foods. I'm going to hold on those questions because I'm thinking that we probably need to hold a webinar and a podcast episode on nutrition at some point, to try to dig into all sorts of those sorts of challenges, because those are I don't have easy magic answers on that. All right. So with that, I'll turn it over to Maria to close us out here.
Great. Thanks, everyone, for this engagement. Well, as we wrap up our time together, we just like to share Early Childhood Health Consultation is here to help answer your health and safety questions for early childhood settings. In addition to webinars such as this one, we do have a podcast titled Teachers, Toddlers, and Tissues that releases monthly episodes. We have an on-demand resource library with print and video resources, and we have a growing number of locations with the aim of statewide support for our health consultation services. So feel free to explore our website if you're interested in learning more about our health consultation service locations. This is a growing number across the state. Feel free to check out the website for those specific details. And celebrating just the growing number there of health consultation service locations. Feel free to listen into our podcast. The collection is growing every month, and now there's 13 episodes available. Save the date for future monthly ECHC webinars. You can see the specific details on our events page. Here on the screen are various ways to reach us: phone call, text, email, the website, and also on social media. We'd like to say a special thank you to the many early childhood providers who offer us guidance, including our very own advisory board of early childhood professionals. We'd like to say a thanks to our colleagues from other childcare health consultation programs across the United States, our current project partners, and our past project team members. As we wrap up today's webinar, we'd just like to make a few reminders. In a moment, we'll be including a survey link in the Zoom chat. This is perfect for any live webinar attendee to offer us feedback in ways we can improve future webinars, and to enter your information if you're interested in registry continuing education credit. Following the event, you will receive an email if you've registered to a link to the recording, as well as a copy of the slides and a link to the survey. Please make sure to fill out the survey if you attended live within the week. And then following the event, any information entered on that post-webinar survey will be entered directly with the registry. If you are interested in receiving continuing education credit and you are watching today's recording, feel free to explore the continuing education log through DCF. And now I'd like to direct your attention, if you are attending the live webinar session, to the Zoom webinar chat. That's where you'll find the survey link for today's session. And as we wrap up, I'll turn it back over to Dr. Navsaria for closing remarks.
Thank you so much, Maria. Thank you for all the lovely comments in the chat. On this webinar, we can't see you, and we certainly can't hear you. So it's great to know that you're finding this useful and helpful. Please tell your friends. Please encourage others. Remember, these webinars are recorded. So if you have new staff or people just new to the field of early childhood education, please suggest that they watch the recordings or listen to the podcast as a way of really getting themselves up to speed in different ways. And we always love hearing from you if you have ideas, suggestions, thoughts. Just want to say thanks and how this has helped you. We love hearing that. It also helps us make a better program. So thank you for all that you do out there for the children and families of Wisconsin, and have a great day.